Welcome to this session. If you're willing, it would be great if you could come forward. That way it makes it a little bit easier for us to engage with the panellists we have for this really exciting session, very interesting session on vaping in focus. So please come forward as you make your way in. Thank you very much for being here. For those of you who I haven't met before, my name is Kate Seear. I'm a professor and an Australian Research Council Future Fellow based at La Trobe University, and I'm delighted to have the opportunity to be the chair of this panel where I imagine I'm going to learn quite a lot from our esteemed panellists about vaping. Before we get going, I'd like to acknowledge that we meet today on the lands of the Wurundjeri people of the Kulin Nation. I'd like to pay my respects to elders past and present, extend my gratitude to any Aboriginal and Torres Strait Islander or other First Nations people who are here with us today. I acknowledge that they remain strong in their enduring connections to land, sky, water and culture, and that sovereignty over these lands has never been ceded. So, we have, as I said, a wonderful panel arranged this morning. I'm going to take you through some housekeeping matters shortly about how it's going to unfold, but let me just start off by setting the scene for you all with a few opening remarks about this landscape, much of which I know will be known to many, if not most of you, but some of it might be new. So vaping, or the use of e-cigarettes or electronic cigarettes or vapes, involves the use of personal devices where consumers inhale aerosol instead of smoke. And as I'm sure you all know, the use of vapes has increased dramatically in Australia in the last few years, including among younger people. According to the 2022 to 2023 National Drug Strategies Household Survey, nearly 20%, or 1 in 5 people aged 14 and over in Australia, have reported having used e-cigarettes at least once in their lifetime, and 7% of people reported currently using e-cigarettes at least daily, weekly, monthly, or less often than monthly. There's been a large increase since 2019, when only 11.3% of people reported using or ever having used e-cigarettes, and only 2.5% were currently using them. So there's been a really dramatic shift in the landscape in the last few years. There are important differences within this population, as I'm sure many of you will know. So males use vapes more than females, although the number of females using vapes has also increased quite significantly in the last few years. And according to the Australian Institute of Health and Welfare, e-cigarette use has increased in the past year among 18 to 24-year-olds fourfold, from 5.3% in 2019 to now sitting at 21%. And there's evidence that some people who use, or many people who use cigarettes and e-cigarettes do so contemporaneously. So there are various concerns and questions that are emerging in this space alongside these trends, as you will know, including concerns that the advent and upsurge in use of vapes might be perhaps renormalising cigarette use, and also, of course, that vapes might be harmful to health. Of great interest to me as a lawyer is the fact that the legal context in this landscape is evolving quite rapidly, and I'm sure it will continue to evolve in the years to come. But in July of last year, the law in Australia changed so that vapes and vaping products can only be sold in pharmacies for the purpose of helping people to quit smoking or manage a nicotine dependence. And further changes were introduced in October of last year, allowing adults to purchase vapes with a lower nicotine concentration from participating pharmacies without a prescription, where state and territory laws allow. But those under the age of 18 need a prescription, as do adults who need vapes with a higher concentration of nicotine. And restrictions on flavours have also been introduced. So as I said, this is a very fast-moving field, and I'm sure I don't need to tell you all that it's also quite a contentious field. My colleagues at Trobe University, Dr. Adrian Farrugia and Professor Sarah McLean, along with colleagues Dr. Kieran Pinner and Julian Nicola, recently conducted a consultation about vaping where they spoke with policy and practice professionals about vaping in Australia. And what they concluded was, and I'll just quote here from their report, that this is a highly contested field in which key professionals held diverse, sometimes diametrically opposed perspectives on the potential harms and benefits of e-cigarette uptake and the most appropriate responses to young people's vaping. They called for urgent research and knowledge translation work, amongst other things. And in my view, grappling with vaping from interdisciplinary perspectives for people with broad expertise is particularly important. And so that's why it's so wonderful that VAADA have put together today's panel, where we have a very diverse group with expertise from a wide range of disciplines. So let's get to them. We have, as I said, a star-studded lineup. You can see their details on the screen, and I'm just going to introduce them all for you at the outset. But today they're going to help us reflect on the various regulatory, ethical, practical and philosophical questions about vaping and how people who vape might be supported into the years ahead. The format of the session is that we're going to ask each of our speakers in turn to offer some opening remarks for only 5 or 6 minutes, just to set the scene from their perspective. And then we're going to move into a panel discussion and a Q&A where I'm going to hand over to all of you for questions. So please start getting your questions ready. We're going to record today's session and it will be made available on a private YouTube channel after the conclusion of the conference. But key to this session absolutely is your participation and your questions for our experts. And then at the end of this session, we'll have lunch served back in the central foyer, and breakout session 4 will begin after lunch at 1:15. So let me just run through and introduce our panellists, many of whom will need no introduction to you, of course. I'd like to welcome Dr. Hester Wilson, first of all, a GP, addiction medicine specialist and chair of the RACGP's Addiction Special Interest Group. Hester is clinical director for Murrumbidgee Drug and Alcohol Services, a medical advisor in southeastern Sydney and a PhD researcher on chronic pain and opioid use disorder. I'd also like to introduce Dr. James Martin down the end, Senior Lecturer in Criminology and Director of the Bachelor of Criminology at Deakin University. James is a leading expert on black markets, cybercrime and the dark web drug trade, and has published extensively and led major research projects funded by national institutions. Can I also introduce Mary Walker, Senior Lecturer in Philosophy at La Trobe University and affiliate of the Centre for Agency, Values and Ethics at Macquarie University. Mary's research spans bioethics, the philosophy of medicine and personal identity, and has published widely on issues including overdiagnosis, neurotechnologies and drug and alcohol policy. Next, we have Dr. David Hayward in the middle. David is Emeritus Professor of Public Policy and Social Economy at RMIT University and a leading expert on social policy funding. He chairs key government reviews and is a regular commentator on Victorian social and economic affairs, including state budget analysis for fee costs. And last but not least, we have Emeritus Professor Wayne Hall from the National Centre for Youth Substance Use Research at the University of Queensland. Wayne is a prolific researcher with nearly 800 publications. How do you find the time, Wayne? But his work has profoundly shaped alcohol and drug education, health policy and epidemiology, as I'm sure you all know. And he's held visiting professorships at leading institutions worldwide. So please join me in welcoming this panel. Okay, and without further ado, I'm going to kick off by handing over to Hester, who's going to talk to us about her perspective.
It's on.
Yeah.
Great. So I'm a GP and addiction specialist, and I guess I really wanted to set this up as a clinician, because many of you are clinicians, around what we see. So Carl, his name changed, age 59, complains of chronic cough. Okay, so this is a kind of a general thing. Maybe you wouldn't be, you know, me as a GP, I'd be seeing people with chronic cough, but you may not be seeing him presenting to you with this, but you'd be seeing him for drug and alcohol issues. Lives with his mum and 2 dogs. Mum is frail and he's her carer. He volunteers at a local service and walks the dogs daily, and he's on disability support pension. He started tobacco at age 12, pretty young, and that makes me think what else is going on at that age. Cannabis age 14, alcohol age 16, heroin age 19, methadone in his 20s, and he's been on and off treatment. He was homeless in his 20s, had some drug-related charges and some short jail sentences and intermittent employment. In the last 10 years, he's been stable on opiate dependence treatment. Currently, he's on a long-acting injectable buprenorphine. He's been using daily tobacco, occasional ice and occasional alcohol use. He also has some health issues, including high blood pressure, chronic obstructive airways disease. He had a heart attack a few years ago and some chronic back pain. Now, how many people in the audience have got a Carl? How many of you see a Carl? Yeah. You know, and so this is the reason that I put this up as a start, you know, that this is the group of people that we do see in drug and alcohol settings. And my Carl, you know, had a life with trauma and with challenge, but my goodness, you know, he'd achieved his goals of getting housed, looking after his mum, he loves his dogs, he's doing some volunteer work, he's stable in treatment, he's using a little bit of, you know, occasional ice and alcohol use, but not at levels that he's worried about, not at hugely risky levels. He's had his Hep C treated, he's doing really well, but the one thing that he continued to do was to smoke. And now he's complaining of this cough. You know what he's got? He's got lung cancer. And what I see happen to Carl over the next little while is that he goes to the oncology people, they do some treatment, he's then in PAL care. It can be really difficult for people that have opiate dependence in PAL care, I'm sure you know that. And he dies of lung cancer at the age of 59. You know, and for me, it's such a tragedy that someone like Carl, who has all the challenges, who's you know, achieved the goals in his life that he wants to, but he continues to smoke. He's tried to give up lots of times. It's not that he doesn't want to give up, but it's really hard to change. And then he dies of lung cancer. You know, and he's also got the other cardiovascular issues going on, which is to do with his smoking as well as other things. So that for me, that is a tragedy, that someone has changed a whole heap of other drug use, but has not changed their tobacco use, their nicotine use, and dies early as a result. So he's diagnosed with lung cancer. And the first question for me is, do we do enough to support people in AOD? I can remember having conversations, my colleagues having conversations, geez, you're doing really well, you've got housing, you're on the opiate program, you know, you're only using 10 cones a day, smoking, you're doing so well. And it's kind of like, our job's done, we've left it there, we haven't gone that next step to thinking about the risk from smoking burnt organic matter, of using tobacco. And how do we have a nuanced response that decreases harm? You know, so for me, my approach is from, I'm a health practitioner, I don't make any moral judgment, but it's around health and how can I ensure good health outcomes. You know, and so Kate, you know, talking about it being contentious, I get it, but for me, it's around the nuanced response for the people that we see. And this response needs to be different for our cows as it does for our 12-year-olds. You know, so really thinking about what are the things that we can do to decrease harm for the people that we see. And the other thing is, I don't know, this might be contentious, but one of the dynamics that happens is people going, well, it's my choice whether I smoke or not. I don't know about that. What I see is that it's the last thing that people change in their lives. And it's really hard to change. And the treatments that we have, none of them work that well, you know, and it's repeated attempts and it's ongoing support and it's periods of time where people cut down or stop, but then they relapse again, as because it's nicotine dependence is a chronic relapsing condition, and it's really hard to shift. And do people still have free will? Once their brains are in the grip of that nicotine, how much free will do they actually have? You know, I don't know what the answer is. I'm hoping that my philosophy colleagues might be able to tell me, but you know, we do know that what happens, and look, and I also understand that people may have different views about what addiction actually is. You know, it's not clearly just a brain disease, but there's no doubt that nicotine hijacks your ability to manage. And we know that's what happens with all the addictions or the dependencies that we see, where people crave it. It does take up a bigger portion of their lives, and it's really hard to shift. And they need support, and they need treatment, they need help, you know, to help them manage that, a chronic relapsing condition. So I guess for me, it's around what can we do earlier for the Carls that we see? What can we do earlier to help them shift that risk and that harm? You know, the cardiovascular, the cancer risk due to nicotine, which is basically a poison. I'm going to finish there.
Thanks, Hester. That's a very useful start to sort of situate us within the practitioner perspective. And I'm going to hand over to James now, who's going to take us through some of the his perspective on the issue. So, James.
Okay, thanks, Kate. Thanks, everyone. So I'm going to keep my comments brief this morning. That's not because I don't have a lot to say. It's because I don't want to monopolise the time, and we're going to share that democratically amongst the fellow panellists. So just to kick off, and this actually, I think, segues quite nicely with what Hester was saying. I've got some stats and figures here, but before I point you towards those, I just want to point out some stats and figures here in Australia. So from the National Drug Strategy Household Survey, the data there is really clear. The amount of, or the prevalence that we see of underage vaping is much lower than many people realise. And I know Stefan and some other people have raised some concerns about whether that's data that's accurately reflecting reality. But what we can say is that the proportion of teen smoking is lower than the proportion of teen vaping is lower than the proportion of teen smoking a decade ago. And nobody was proposing to ban cigarettes and to regulate cigarettes then the way we have now. 93% of the people who vape in Australia, current vapers, are over the age of 18. This is overwhelmingly an adult phenomenon. It is not a youth phenomenon. So what I want to do now, just in the brief time in my opening statements, is point towards some alternative regulatory models, because in my view, we here in Australia have overwhelmingly, and I think largely due to a bit of a moral panic around youth vaping, we have created an over-regulatory space where we are focusing on that. 7% of teen vapers, only a small proportion of which are actually daily or regular users of vapes. And we've created a whole policy to suit them rather than people like Carl, for example. So here's some stats of some other countries that do a little bit differently. So you can see here, if we have, so I just focus on this graph on the right first. If you look at daily smoking rates in New Zealand, consistently higher than they were in Australia. And then, of course, we see this big change here occurring around 2020. What was the big change? Of course, it was the legalisation of vapes. So in New Zealand, vapes can be sold from specialty vape shops, licensed shops. You don't have the flavour restrictions and the limitations on devices that we do there, although there are limits on the concentrations of nicotine that we see in those devices. And those nicotine limits that they have are far lower than the black market vapes that dominate the Australian market at the moment. This is one of the classic iron laws of prohibition. As soon as you ban any kind of substance, you get higher potency substances coming in. So the disposable vapes, the ones that are kind of the curse in Australia at the moment, are not prevalent in New Zealand because they have that legal regulated market and products are subject to safety standards. So what you can see here is a dramatic decline in smoking as soon as vaping was regulated. Vaping is the #1 smoking cessation aid in any jurisdiction in which it's been legalised. So it's the #1 quitting aid in the UK, #1 in New Zealand, more effective than any other nicotine replacement therapy, more effective than cold turkey. It's the only smoking cessation intervention that is so effective that smokers not intending to quit who try a vape, a high proportion of them will end up quitting smoking. Right? They will just voluntarily switch to vapes. Now, there is concern, of course, in New Zealand, like in the UK, like here in Australia, around youth vaping. So we can see here, this is, the blue line is the youth smoking rate, and you can see here dramatic decline in youth smoking, but a significant increase in youth vaping as well. So peaked up around 10%, but we're seeing declines in that now. Those declines we're also seeing, starting to see in other countries too. Early data from the Generation Vape project here has showed that teen vaping has peaked here, or may have peaked here, starting to decline in New Zealand, and has declined dramatically in the United States. So my sense, taken for what it's worth, is that teen vaping is a bit of a fad. I'm not saying that regulation isn't important here, but when you hear about these large increases, 500% in teen vaping, that's from zero, so I think we need to keep these overall numbers in perspective. More important, and I think this is where my thoughts coincide with Hester's here, is looking at more priority populations in terms of smoking prevalence. So we know this is a huge problem here in Australia. If we look at First Nations people's smoking rates and smoking rates amongst lower socioeconomic groups, this is where vaping has been remarkably effective in New Zealand. So if you look at Maori people, you can see consistently high smoking rates. These are sort of consistent roughly with what we see with Indigenous Australians, and you see this dramatic shift. As soon as vaping is legalised, you see very steep declines, and that decline is ongoing as the uptake in vaping has occurred. So too do you see those kind of dramatic declines amongst the lower socioeconomic quintiles in New Zealand. Biggest shifts have been amongst the lower socioeconomic groups. So it's really effective in driving smoking cessation amongst those priority populations. This, and this will be my final point here as well, speaks to, in my mind, the moral panic around youth vaping in Australia has been driven by two things. One, an overestimation of the prevalence of youth vaping. It's not as high, at least with the data that we have, and we like to think we're being data-driven, is not as high as many people assume. It is an adult phenomenon. The other one, and you will have heard this headline from the New South Wales Cancer Council, is that vaping is a gateway to smoking, right? We don't want teens vaping, because even if vaping isn't as bad as smoking, teens are 5 times more likely to go on to smoke. This implies causation rather than what we're actually seeing. The far more likely explanation is common liability. The kind of person who is likely to try vaping is also a more risk hungry teen, who's also the kind of person that's going to take up vaping. That's not to say that some teens won't try vaping and go on to smoke. We know that there are teens that are doing that, particularly as the understanding of the harms of vapes, well, the misunderstanding of the harms of vapes. There are many smokers, particularly amongst older age groups, that think vaping is as bad, if not more harmful than smoking, and as that misunderstanding becomes more common, we'll see that. But the important thing to note about the gateway theory is we're not seeing it. We're not seeing it amongst young people, we're not seeing it amongst older people as well. In fact, in no jurisdiction anywhere in the world are we seeing increases in smoking amongst age cohorts that are taking up vaping. All the large-scale population surveys tell us exactly the same thing, and that is we see the opposite occurring. We see substitution happening. We see the biggest falls in smoking prevalence amongst those age cohorts that are taking up vaping in the largest numbers. So I'll leave that there and I'll pass on, but yeah, looking forward to your questions. Thanks.
Thanks, James. Okay, next we're going to hand over to Mary, who is our philosopher, and Mary's going to take us through things from her perspective. You want to come up here, Mary? Yep.
Thank you. I just want to have my notes in front of me, otherwise I'll ramble on for far too long. Right, so my contribution is about the ethics of this vexed issue, and I'm going to draw specifically on a practical ethics approach developed by Nancy Cass, and I've made the title make it sound more complicated than it really is, I've just realised, but it just asks us, she gives us a framework which asks us to think through a series of fairly simple questions, to think about whether an intervention, a public health intervention, has an aim that is itself ethically legitimate, second question, whether it has a reasonable chance of succeeding at meeting that aim, whether it causes burdens, and if the burdens whether it's the least burdensome way we can achieve the aims, and whether the benefits and burdens are fairly distributed. And then overall, she wants us to think about whether any burdens imposed by a public health intervention are are justified, are proportionate to the aims. So the terms in the title there are just the kind of jargon in the field that we use to make those points. This one? Yeah, thanks. So to apply this to vaping regulation as it is in Australia at the moment, obviously this will be very quick and overviewy, but others are giving more detail on things. So the aims of our vaping regulation, so one is smoking cessation, using vapes as a therapy, harm reduction, or as the TGA puts it, managing nicotine dependence, and prevention. So preventing especially young people from taking up vaping. So the first two are captured by our pharmacy supply system as we have now, and the third, the prevention aim, is captured in the broader restrictions beyond that medical context. So effectiveness, people might disagree with what I put here, but the evidence is developing. There's a Cochrane review, as James has said, showing effectiveness of vaping for smoking cessation, although at the moment Australia's guidelines from the RACGP don't recommend it as a first-line treatment, but potentially effective for some. Effectiveness for harm reduction, we know it's less harmful than smoking. I'm fairly sure that's not controversial, but also that it's not harm-free. And as we've heard, so far the regulations Australia has for preventing uptake of vaping have not been effective, and there are reasons to think that the system we have at the moment won't be effective. So known or potential burdens, I've put the same thing here for our first two aims because I think it's the same. So just that the current system that we have might make it more difficult to access than it should ideally be for people that could benefit, including for some people who use drugs, who are an underserved population for health services in general in Australia. So this is harms of the regulation in particular rather than harms of vaping itself. Harms of regulation aimed at prevention, so the restrictions that we have, and I'm sure this isn't exhaustive, but we seem to risk stigmatising people who vape. Potentially, I've put criminalising there, I'm not sure how kind of likely that is, but I suppose it's potentially could happen. Importantly, shifting people onto more harmful products, whether that's black market vapes or which carry more harms or are more likely to carry harms, or tobacco products. And then there are kind of more distal harms or social level harms, like encouraging a black market that finances organised crime, and the negative environmental effects. Next, are there other approaches that would be less harmful? Following from the above about limiting access for health harms, seems to suggest that there's been this move to pharmacy supply without a script in October last year. That seems to be arguably positive, but there's still potentially access issues. In terms of what the less harmful approach would look like, I'm not qualified to talk about, but others on the panel are speaking to that. Yeah, and I've just put this one as a question, and I guess this is in many ways the sticking point, that there probably are approaches to prevention that are less burdensome and also hopefully more effective. Okay, finally, wrong button. Does the intervention fairly distribute the benefits and burdens? It does seem like the current system, I think, disadvantages some groups more than others. Namely, it disadvantages those who can't access vaping products or don't access vaping products in this system, who could have benefited from them and therefore continue to smoke and bear the costs of that. While the benefits of the system, what prevention it does achieve, and it doesn't seem to be very good at that, but whatever it does achieve, don't go to that group, but to another group of never smokers who avoid taking it up. Okay, so this obviously doesn't resolve what to do, but hopefully just gives another perspective on the different trade-offs that are involved when we have these different aims that don't necessarily fit together very well or very easily. And in particular, what I wanted to bring out is that as is often the way, I think, in policy decisions of these kinds, the policy is attempting to respond to a perceived harm, to reduce harm, or prevent harm, or address harm. They also, though, introduce other harms, right? And in addition to that, they can do what I sometimes think of as an ethical harm, which we could think of as placing burdens on some groups that are already less advantaged to benefit other groups. And that's not always ethically problematic to do that. We have lots of policies that do that, and it's not always a bad thing. But at least according to most theories of justice and most ethicists will find it at least questionable if we have a policy that places more burdens onto a population that is already less advantaged than other populations, that's a potential sign that that particular policy is out of step with our health justice aims and also with our social justice aims. And that was really the one point that I wanted to make. Thank you.
Thanks so much, Mary. There's a very rich set of issues emerging. So as I mentioned earlier, please make sure you're coming up with your questions for when we finish with our panellists. Next, I'm going to turn to David, who's going to take things from here and share his perspective with us. So, David.
Hi, everybody. Thanks very much for coming today and listening to me. My background is public policy. I don't have a background in alcohol and other drugs, but I do have a very strong interest in the issue of care. And it came out of some research that I was doing a number of years ago into the NDIS and the care economy more broadly. And it drew me into some literature that I hadn't come across before around the ethics of care. And that's what I really want to talk about today. But I want to sort of do it in a circuitous route. So if I was to address the question of should there be regulation over vapes, the answer would be it depends, and you'll get the point of my title presently. So when you think about any public policy issue, one of the things you'll discover from the public policy literature is that there isn't just one approach, there's usually a number, and those approaches are driven by values. And quite often the approaches involve values that become so fundamental to the person who advocates them, they can't even be in the room with somebody who advocates another approach. There's no conversation as possible. I've just put up here 3 approaches from a brief scan of the literature that I've undertaken. So the first one, to my surprise, I thought, let me do a Google search for a neoclassical economic study of vaping in Australia, and I got one. Very first one, it was an American study by 6 economists at Cornell University who got some funding from the American Economic Society to look at our vaping policy that was in effect until midway through last year. So what do they see? They see utility maximising individuals, self-interested individuals. They're confident that you can measure people's utility and satisfaction so well that you can put a dollar value to it. And at the end of their study, they say, look, we could benefit Australians by 1.7 billion by getting rid of the prescription on choice and just allowing people to go to a chemist, for example, to get a script for a vape, to choose it. Otherwise, just freely acquire vapes from wherever there is a legitimate retail outlet. 1.7 billion, that's how confident they are. Second approach, public policy, which I've split into 2, a public health approach, probably bioethics might be in there, and a human rights approach, and often the 2 come together. But what they share in common with the first approach is that they see individuals with rights. And this approach tends to take a different approach to the economic one in that it tends towards stopping, preventing, outlawing, severely restricting access to vapes. And it's quite often founded on detailed research, scientific research, but there's some certainty, like the Australian College of General Practitioners with their guidelines will say, this is certain, this is relatively certain, this is uncertain. Which brings me to the third approach, which is the ethics of care. And if you haven't come across this literature, I do encourage you to read it. For some reason, it's largely hidden here in Australia. It's pretty prominent in Europe and North America, but here we don't discuss it very much. The book that I would refer you to in particular is Carol Gilligan's book, In a Different Voice, which was published in 1982. And it's about the moral development of the child. And she looks at the literature that was available and she says, look, this is fantastic stuff. The only problem is the children that are the subject of the research are all, guess what, boys. There were no girls in those foundational studies. And when she undertook her own research, what she found was not one pathway for the moral development of children, but two. One based on an ethic of justice, which tended to be the way the boys saw the world, and there was another one that girls tended to see the world, and that was an ethic of care. The ethic of care is grounded in relationships, of complexity, the need to have a conversation, the need to have empathy with the other, the idea that we're all involved in dependent relationships. We're not autonomous beings at all. It's relative degrees of dependence. That we all have the right to care for others as well as to be cared for. And when she undertook her research with the girls, if she chose a particular scenario, that it could be, there's a famous one involving Hines, who has to get some drugs to save his wife who's dying. He can't afford them, and the question is, should he steal them? When the boys are asked, the boys come up with an answer based on theories of justice and rights and so on. The girls give it a different answer. It depends, they say. It depends on the context. Maybe the Hines should have a conversation with the chemist to let the chemist know what's going on, because maybe a different answer will come back. Maybe it just depends, because if they steal the drugs, they might end up in jail and the wife could die anyway. So it becomes very complex, and they put together a picture based on care and relationships that change over time. This third approach, the ethics of care, I think, Hester, that's what you're talking about, that's what you do, right? And it's very different from the second approach and the first approach, which tends to see individuals, autonomous individuals who have rights or utility maximisers. It's much more complex, much more nuanced. It puts the emphasis on you as the practitioner to situate the conversation and listen to the other. So there's no hard and fast rules that apply everywhere and in every space. It's a one-by-one proposition, very much focused on the groups that are most at risk from this. So look, I hope you'll see in why the title of my talk was It Depends. So it depends in a double sense. What's your framework? But if you take the ethics of care approach, it is always, and the answer is always, it depends. Thanks very much for listening.
Thanks, David. All right. Next, we've got Wayne. I'll just skip through to your slide, Wayne.
I can be reasonably brief because a lot of the territory has been well covered by James and the other panellists. This is a topic I've been around since 2016 when we introduced the prescription system. And at that point, it seemed like a sensible approach. E-cigarettes weren't very big. There wasn't a lot of demand for them. The TGA were reasonably confident that e-cigarettes would be, an e-cigarette would be approved as a therapeutic good and could be prescribed. But what we've seen is that system has basically evolved into de facto prohibition, because there are no products that are approved, and we've had strong discouragement from a lot of organised medicine, the colleges, the AMA, NHMRC and various other bodies to discourage doctors from prescribing. And so we have a nominal prescription system that has no products to prescribe and very few people to prescribe. So the consequences of that have largely been that most people who access these products have done so illegally through retail outlets, initially exploiting the loophole that it was legal to sell vapes that didn't contain nicotine, which were being marketed, in fact, as in that sort of guise. I can't really, I might have to stand up, Kurt, and see it.
Of course.
See my own slides from there.
And there's, you can see down there or up there.
Up there.
Yeah.
Thanks. I think the policy has failed to achieve its objectives. I mean, primarily, I think James is absolutely right. The policy has largely been driven by the goal of attempting to prevent youth uptake. And I think a lot of the sort of panic around that has been overestimating the prevalence, which I think has had the unintended consequence of encouraging youth curiosity. Because if you believe that everybody's doing it, what am I missing out on? And I think that's been a lot of what we've seen in the faddish quality around vaping in many countries. I haven't presented the data, but it is clear that we've failed to prevent youth uptake. We've failed to provide smokers with legal means of accessing vapes, and we've discouraged doctors from prescribing and using vapes, and we've got an illicit market out there, which has become more illicit with the changes in policy. And I think one of the sad things about this policy, as someone who's been in public health for the better part of 40 years, has been the polarisation of opinion and the discouragement, the discounting of evidence that vapes are effective. This is particularly in the NHMRC statement on this, driven by Emily Banks's review. And the more recent Cochrane review is now saying that there's pretty convincing evidence that vapes, nicotine-based vapes, are more effective than NRT. And I think that's the case. But even if it wasn't, even if they're only as effective as NRT, I think it should be an option that people have. We've also seen an exaggeration of the harms of vaping. We still, in this country, mistakenly attribute the EVALI outbreak of lung injury in the US to nicotine vaping, but clearly wasn't. That it came and went. There was an outbreak that peaked 3 or 4 years ago, and there's been no substantial numbers of people reporting that sort of syndrome, despite the huge increase in nicotine vaping. And the gateway to smoking, I think, is something that's been overestimated for the reasons that James has already indicated. And I think the sad thing has been the refusal to engage in public debate. There's no debate about this in the public health community, because the argument often is put that if you're not in favour of a ban on vapes, then you're in the bed with the tobacco industry, and we don't talk to the tobacco industry or anybody who's in bed with them. And I think stigmatising the critics of the current policy, and I've seen that not directly. I mean, I don't know what people say on social media about me because I'm not on social media, but certainly I know some of my colleagues have been given a pretty tough time because of their support for a more liberal regulated policy. I think the sad thing about Australian policy is it's presented as a forced choice. We either have to ban these products or anything goes. I think we certainly could come up with more sensible ways of regulating vapes and tobacco. I think we should be licensing all distributors of tobacco and vaping products and regulating the way in which they're sold and promoted, and regulating the type of products that people can purchase in the way that James has outlined has been done in New Zealand. And I'll finish there. Thanks.
Terrific, and thank you to all of our presenters for keeping to time, because there's so much that could have been said here, and they've all done a really great job in giving us a wide range of a kind of sense of the issues so that we can now have a discussion. I have plenty of questions for the panel, and I'm happy to kick a discussion off, but I'd like to just open to the floor first to see if anyone has a burning question they'd like to begin with. Otherwise, I'll open. So if you do, just throw your hand up. Yes, I can see a hand here. Do we have a roaming mic somewhere? Oh, thanks, James. So, okay, great. I can see that James might be able to help me. I'll grab a, oh, thanks. Thanks, James. All right, we'll go here at the front first, then here, and then here. So we've got 3 questions to kick us off. And maybe, if you don't mind, just say your name and where you're from first so we can all hear you.
So Joe Coyte from the Glen Group, so Aboriginal Community Controlled Services in New South Wales. My question was actually for James, so it's handy that he's close. Do you know, with New Zealand, do they have much of a black market? And how do they get the price point right over there? Having it legalised, having it regulated. So how do they sort of get that balance right of getting the regulation right so you don't still get that black market?
Yeah, that's a great question. Yeah, thanks. So to my understanding, there is no the black market for vapes is negligible in New Zealand. There just isn't one, and that's largely because the products themselves are very affordable and very accessible. So yeah, my understanding is there's very little tax on vaping products in New Zealand. Somebody else might be able to speak to the details of that. I'm not sure exactly what the prices are, but they're lower, much lower than they are here in Australia. And of course, I think the really critical thing is the flavour restrictions. So, you know, the flavours that we have legal here from pharmacies, if you can find a pharmacy that will dispense a vape, mint, menthol and tobacco, they're the least popular flavours amongst adults and ex-smokers who vape. Actually, the studies that show that mint flavour particularly is more favourable amongst teens than it is amongst older people. So kind of probably got that wrong if that's the intention of the policy. But I think, you know, a real issue around that is here in Australia we want to medicalise vapes. We want, you know, to pathologise people who vape, you know, as people who are sick and in need of medicine. And I think in New Zealand they have a different approach. You know, it's marketed as a consumer choice. You know, there's public health campaigns. If you smoke, you should switch to vaping. And they've actually got switch to quit kits as well. So if you're a smoker, you can get a free vape at taxpayer expense over there. And they've got similar schemes in the UK. I think the licensed approach is the way to go. I think in the UK, I was there last year, vapes are absolutely everywhere. And even as someone who thinks that vapes are a good idea and should be available from specialty, licensed shops, I think the UK is increased access too far. So I think the New Zealand model has got it pretty much right.
Thanks, James. And before I come to you up there for our next question, I might just ask Wayne if you wanted to chip in anything there, because I know you have written about the New Zealand approach.
I think James had summarised it earlier. There's been a bigger increase in youth vaping in New Zealand than Australia because these products are more accessible. But the big thing there has been the acceleration in the decline in smoking prevalence amongst adults, but a lack of an increase in smoking amongst adolescents. So vaping is replacing or displacing smoking there. And it seems to be on the way down, as James presented the graph. The same thing's happened in the US. They had a much bigger uptake of vaping there, and that's declined really radically over the last, I think, 3 or 4 years. One topic I haven't raised, the preoccupation with vaping. There are nicotine products that are even much safer than vaping that we banned in 1991, oral nicotine products. And we're now sort of gearing up for another moral panic around nicotine, oral forms of nicotine, like the one that we've now had about vaping. So we get people claiming that there's no difference, whereas we've got 30 years of experience in Sweden indicating that these products are much, much safer. And those are the products that if we wanted to be concerned about respiratory risk of vaping, those are the products we should be looking to.
Thanks, James and Wayne, and thank you very much for the question. Okay, I'll come up to the back, and James Petty, thank you. If you don't mind helping, that'd be great.
Thanks, guys, for your presentations. I just a couple of things. First, a bit of a reflection. So I'm a person who used nicotine vapes to quit smoking, and am now nearly 2 years free from nicotine. But I'm also an addict who hates being told what to do. So when I used them, I was using the units where you could buy the flavoured liquid and then get the nicotine separately, mix it yourself, and I felt like I had control over it. And I feel that we're trying to do it, from this new kind of like pharmaceutical lens, I feel like I might not have been as successful. I've also found, I work in AOD, so, the technology, social media's algorithms kind of got me pegged for what I'm interested in. But I found since the legislation's in Australia, I've been seeing more and more sponsored and endorsed ads for black market vapes on social media platforms. So I'm just interested in any of you guys' thoughts, reflections, mainly what's the main driver behind kind of not allowing or like looking down on that mix it yourself vape model, and what can be done about the ads popping up on social media sites where young people particularly are utilising often?
Okay, thank you so much for your perspective in those questions. Who wants to have a go at either or both of those? Hester, and then maybe
I'll
Wayne.
have a go at the open chamber where you can put your own stuff in. My understanding is there's not a lot of evidence out there. However, anecdotally, and I've had conversations with people that have very successfully changed their vaping by slowly decreasing the concentration. And for some people, that sense of being in control and I'm managing this is really important. So I think it's an option, and it's something that I will always say to people, that's an option that you can use. The issue with the open system is potentially, and look, it's very uncommon, but child poisoning potentially with those. But that wouldn't for me, that wouldn't stop me from suggesting it, but it would be flagging, look, there is a risk, how are you going to manage this? You know, so because it's around people having informed choice around what's going to work for them. And look, and I have to own that I'm a clinician, so I kind of think that, well, you know, people coming along and seeing me, the idea is that I can support them and make it easier for them to quit. So I'm disappointed to hear that it feels like that would constrain you more. But because from my point of view as a clinician, it's around working with individuals as I see them, you know, around what their goals are and helping them achieve those goals and working through scenarios that are going to be achievable for them. I hope that's answered your first one. The second one I don't know the answer to.
I think Wayne was going to have a crack. Wayne?
Yeah, I mean, I agree with the first one. I think the important point to make in the UK for a very long time, those sort of modifiable devices have dominated the market and were one of the ones that a lot of former smokers used to quit. And I think you're right, if you move to a prescription model, then regulators like standardised products and want to deliver particular doses and so on, so that sort of degree of choice is removed. I think the social media, we've been documenting the extent of promotion of vaping products, particularly young people, and there's an enormous amounts of it out there. And as you indicate, the algorithms, if they detect an interest in a particular product, will deluge you with advertisements. And I think given the President Elon Musk, the chances of regulating social media are probably fairly low, but that's clearly what we need to do. I looked at one point at the product Zim, which is one of these oral nicotine products, and I still get ads pointed at me. So that the algorithms of these social media are very powerful, and they obviously identify characteristics of individuals and target stuff at them. I think the sort of products that are being sold in the illicit market, a lot of them come from China, and they're interested in maximising uptake, and they're not too fussy about who they sell to. So I think that's been one of the unintended consequences of prohibiting and medicalising these products.
And James, yeah.
Thanks, Wayne. Thanks, Kate. I'll just make a very quick comment. I think what we've seen with the approach from the government, both with regulation of social media and with vapes, is you take a complex social problem in need of a nuanced policy solution, and instead we get a prohibition. We just go, let's ban it for everyone. And I think that is a kind of tough law and order style of politics that resonates in a short-term political sense, but I don't think it really helps things. I think we do need to look at things like the Europeans, regulating social media giants, looking for that nuanced policy solution rather than, I'm tough against vapes or I'm tough against social media and passing a ban. I mean, the ban on social media for teenagers is about as effective as the ban on vapes. There's no discussion actually of how practically that can be implemented and what the real world effects would be.
Can I just make a point about being in control? For us as GPs, for my pharmacy colleagues, we weren't involved in the decisions to say that we're the ones that are going to prescribe, and the pharmacists weren't involved in where that they're going to be the ones that are going to have this in their shops. And the overwhelming feedback I get from my GP colleagues and from my pharmacy colleagues is, we don't want to do this. Why would we do this? We weren't involved in this, and we're told we're going to have to prescribe these unapproved products, and there's hundreds of them, and so we don't like being told what to do either.
Before I come to our next question in the audience, Hester, can I just ask you to say a little bit more about that? Because as you know, I was keen to hear a little bit more from your perspective as a GP, what it's like to now be working within this model. And do you feel that there is the necessary expertise and support and infrastructure around you to understand how to navigate this new world, this new landscape?
The short answer is no, but one of the interesting things is I'm very open to talking to people about what it is that they need to do to reach their aims, their goals. But I went through the TGA site, I know how to prescribe if I need to, but I haven't had anyone ask me. And I actually went on to a social media page for GPs and said, guys, is anybody prescribing? And everybody said, no, we haven't been asked. And when I ask people who are vaping, they say, I can get it easily, illicitly. It's much easier than coming into you, and I get the type that I like. So I think that there's some anxiety on the part of some GPs, unapproved, we don't have the skills. And we tried to respond to that from the College of GPs, writing papers, updating the guidelines to support GPs, doing presentations. We did a whole heap of work to get ready for these October changes. But the reality is we're not prescribing.
Mm-hmm.
And I don't know, talking to my pharmacy colleagues, I don't know how many of them have actually got the units into their pharmacies because there's not demand.
Mm.
People are easily able to continue accessing the illicits and they're cheaper.
Yeah, and hearing you say this makes me think also about Mary's observations on about the way that a burden falls upon populations. I'm thinking about how with the decline of bulk billing and issues with Medicare and Medicare rebates, you know, that for many people even going to see a GP or to find a GP, having to pay now increasingly for a GP is an extra expense that will also disproportionately impact particularly people from lower socioeconomic groups.
It breaks my heart that the way that we are underfunding our primary care services means that the people that I see, many who live in poverty, cannot afford to seek healthcare. We see it from the ABS data. It's tragic.
Yeah. Mary, did you want to just add something on that?
Actually, maybe not. I think Hester might have said it all. Yeah, I mean, for me, that's. There's a lot about this issue, as I said before, that I'm not qualified to weigh in on or make judgment calls about. But I'm fairly confident in saying that it doesn't seem like a policy that is in step with health justice goals or with health equity goals for exactly that kind of reason.
Yeah. Okay. I'll come to our next question and then I've got one up the back there. So thank you, James.
I'm Bree. I'm from Odyssey. I'm the lead psychologist across all 3 residential rehabs. I had a big tirade here about funding and policy and ministers and all that sort of stuff, but I thought I'd skip through that bit because everybody knows about that stuff. I'm kind of more interested in some feedback around what you guys think when it comes to the effects of banning smoking in public and then banning smoking in any government facility. So in forensic settings and in residential rehabilitation settings, and then thinking about that idea of supporting people in their choice to cease nicotine, but not really providing them with a plethora of choice when it comes to ceasing nicotine. And okay, you can come to rehab, but you have to quit smoking, and this is the only option that we have, and you have to do that one. And if you get caught with a vape, you're going to get kicked out. And I think there's a lot of organisational challenges when it comes to the cost of NRT as well. So your traditional NRT being very expensive. And then there's the favoured use of only using NRT for the reasons that GP, can't remember your name,
Hester.
There. And I mean, I've even visited my local chemist and spoken to them about prescribing vapes. Now they have them in stock, but none of the chemists there know what to do with them. And they're reticent to do it because they all have those fears around TGA and those sorts of things. And none of them have done the training and they don't know what to do. And so I guess I've just wanted to raise that and get some feedback and ideas. And also wanted to just say, like in regard to youth vaping as well, why is nobody talking about the fact that the youth vaping is all happening with vapes that are unregulated? If we regulated these things, we would know what they were using. And then there's the health stance. I mean, at least then we know what's happening. But at the moment, it's because it's happening with these devices that are coming from China with no regulation whatsoever. So, yeah, that's me.
Thanks, Bree. There's a lot of really important issues packed in there, and I wonder who'd like to have a go first. I wonder if, David, if you have anything you'd like to explore there, particularly perhaps around Bree's initial comments on banning spaces and then kind of people having few alternative choices, and if you have any reflections from a public policy expert perspective.
I think actually in the way you framed your observations, you also shaped the answer, which is around trying to understand the person and engaging with them rather than making rules, hard and fast rules in advance, which that's kind of like the opposite of the ethics of care, where you are meant to be there's another element to that as well, which I didn't mention. There's a fantastic book by an American sociologist called Richard Sennett called Respect. The book is posed as how do you have respect in a society of great inequality, where inequality is getting worse and welfare is being cut back. And one of his key points is it's a wonderful book, but one of his key points is that you must allow people to have a say in the conditions of their existence. They must have a voice, right? And if at the beginning there is no voice, well, you've taken away that aspect of respect, which I think is sort of connected up with that sense of control and dignity. So I think where you were headed with your question, which is that they're probably not the right policy settings in a very difficult context, that's how I would tend to position that answer. So, yeah.
Thanks, David. And anyone else like to chime in on the other aspects of Bree's? I mean, I'm particularly interested in those issues that you're talking about, Bree, in relation to rehab, the need to quit smoking, no vapes being allowed. Is that something? I mean, Hester, I'm looking to you because I feel like as our clinician, you might have some thoughts on that.
It's really tricky. And I think, you know, the reality is it's really easy just to say, no, we're not doing it. You know, there's a black and white answer and we're just going to say no. But you're absolutely right.
It's even more complicated when staff walk off site and vape.
Oh, absolutely, absolutely. Look, and I can remember...
And some people who are more advanced in a program are allowed to leave and vape.
Yeah.
People who are early in the program are not. There's inconsistency.
Yeah, we need a more nuanced approach.
Yeah.
You know, and it needs to my mind, it's about conversation. It's about what are the goals of the person? How can we facilitate that? But at the same time, you don't want to subject your staff to passive smoking. You know, there's a risk there. So how do you have an environment where that can work? You don't want to have a situation where someone who has given up smoking is saying, I just can't be around smokers. You know, so it's tricky. Our NRT doses are woefully low. You know, so one of the things I work with a group of people where 90% of them smoke. You know, it's really high prevalence and they're highly nicotine dependent. And we look at all the different options. You know, they need 2 or 3 or 4 patches a day. You know, and at the moment under PBS, you can only get a certain amount. Don't get me started on the whole cost thing. But in an NGO, you know, are you able to access PBS? Probably not. So you've got to buy it, which is a huge expense. It's really tricky. And I guess the only thing I can say is I would really love us to have a more nuanced response. But it just feels like it's kind of like just say no. You know, and I'm also really interested in the fact that it seems to me like the changes that we've had in smoking levels in Australia have been based on stigma, you know, and they've worked in the general community because it does work, but with the group of people who are still smoking now, potentially, it doesn't work and it becomes more stigmatising. He's nodding.
Okay. No, all right. Thank you for those answers and thanks so much for those questions. I'll come up the back. And then I'll come over here. Yep, great. Thank you.
Hi, I'm Patrick. I'm a psychiatrist working in addiction in Melbourne. I guess a couple of comments. I mean, I was in New Zealand recently and you could see, you went into the local supermarket and there were vapes up on the shelves next to the cigarettes. And that does seem to be it seems crazy that we have readily available cigarettes, but there are barriers in place for a product that, yes, it's addictive, and yes, there may be some harms associated with it. It doesn't give you cancer, probably. It doesn't cause heart disease, all of these sorts of things, and definitely is much, much safer. So putting these barriers in place. And I'm interested in this debate because there's not a single person who actually is defending the policy in terms of the government's position. And is this just policy by Daily Mail? I'd say something about that.
Wayne, yes, please.
I mean, I don't think it's an accident. You don't get debates on this because the position that people often take, as I think I indicated briefly, is that it's often said debating e-cigarette policy is like debating with an anti-vaxxer. If you don't support the ban, then you're in bed with the tobacco industry. And so you don't get people prepared to defend the policy. And I think that's a sad commentary on the field of public health that we are not allowed to have these sorts of debates. It's not possible to have a reasonable discussion, I think, as David said, about the pros and cons of current policy. And we've just largely doubled down in the face of failure by increasing penalties, making it more difficult for people to access these products. And as you said, I mean, our current policy is like banning codeine and allowing heroin to be sold on corner stores. It makes no sense.
Thanks, Wayne. And I might just offer a reflection before we come to the next question. I think your comments earlier about the regulation of social media and President Musk, as you referred to him, I think are really significant, because for those of us who are on social media, or even just now observing social media and thinking of leaving, like I am, for a long time something like Twitter did operate as a platform for these debates to unfold, and that has become increasingly a very difficult space to even sort of try to learn what the different perspectives might be, given the way algorithms work and the like. And I think that does have that's a very important piece of the regulatory question for me, is how to manage all of those forces. And David, I can see you've got something to say on that too.
There's a review that was done last year of the COVID response, and I'm not sure how many people in the room have read it, but it is worth reading. There's a chapter in there on trust in government, and they talk about the impact of the harsh shutdown policies on people's confidence in government, and they talk about a decline in trust. So it's interesting that the argument in there was that governments have got a lot to do to make up for the mess that they created. And they go on to talk about survey results that they had conducted, and they found that there was a significant minority of Australians who now had a strong distrust of government. By and large, they were white men who got their information from the internet, in particular from social media sources, and they didn't believe in science anymore. I think what you can take from that is that if you put two things together, prohibit on the one hand, harsh regulation together with deregulation in the social media environment, you put those two together, you have a really toxic cocktail of policy decisions. And unfortunately, I think that's where we are at the moment. And I'm afraid that can only end in disaster.
Yeah, just to make the point, and people are aware that I wasn't talking idly about President Musk. One of the things that Trump is threatening is sanctions against European Union if they impose restrictions of the sort that James was talking about on social media. So I think there's a real risk of finding it very difficult to regulate media in any way, shape or form.
Yep.
And I think that'd be bad for all the reasons David's in.
Yeah, absolutely agreed. And I think this is a very valuable perspective, so I appreciate you bringing it. Okay, next question up the back.
I'm not sure if it's a question, but I'd be interested in you commenting on this. So after decades of receiving referrals and assessments from the AOD sector, I just am still stunned at how blind our sector has been to addressing tobacco. So as a new worker, you come in, you're like, methamphetamine, cannabis and heroin, oh, it's so exciting. And we are blind to tobacco. We're giving more oxygen to vaping, and yet we still ignore tobacco. So we're often turning people away. So this is more of it's not really a criticism of our sector, but it's a plea to stop ignoring our own blind spot, that you as a worker can find out more about methamphetamine and what it comes in, but you won't know how to support. So picking up your point, Hester, about the role of a clinician saying, my job is to support the consumer choice, but we as the sector don't actually have the ability in many ways to even support tobacco cessation. So despite Quick Victoria and resources and pamphlets and information, we have been unable to go there because we've bought into picking up the point that, a person can say, oh, I don't want to give this up now. And we just go, oh, that's what they choose. But they're stuck. They're stuck in this ethic of I am disempowered. And I actually don't know how to get my way out of it. And you as the clinician have just blindly gone, oh, okay, you don't want to give up. But that's not really the case, because they actually do want to give up through the impoverishment, through the decades of being entrenched in this behaviour. So we'll happily work with their methamphetamine use and their other substance use and almost accept that being stuck in tobacco is an actual choice. Anyway, so I guess I'm wanting to hear almost something from the panel about what we as the sector can do as clinicians to make sure that we take the opportunity with vaping to also go into a place we don't want to and look at the evidence about tobacco and supporting people to stop smoking.
Thank you. James.
Thanks, Wayne. Thanks for the question. Not being a clinician, I'll keep my comments brief, but I would just point back to, I take your point, I think a lot of smokers do want to quit, but it's a pleasurable part of their day, it's addiction, all those kinds of things. I think what the evidence from overseas is showing us really clearly, and I mean Sweden is the best example of this, is when you give smokers a range of pleasurable nicotine options, right? So Wayne mentioned the nicotine pouches before, entirely synthetic, same risk profile as nicotine gums or sprays. Vapes, smokers will transition through a range of those products to quit, and that's being reflected, and if we look at Sweden, their nicotine usage rates is consistent with the European average. There's the same proportion of Swedish people using nicotine as there are in other European countries. But the risk profile is dramatically different. Sweden has the lowest tobacco-related morbidity and mortality in Europe, and that's because of the proliferation of these less harmful nicotine products, snus, nicotine pouches, and vapes.
Anyone else?
Just
Wayne.
add to that, I think the case history that Hester chose is well chosen, because the great majority of people with alcohol and drug problems die of tobacco-related diseases at a younger age than they do from the harms caused by the drugs, the primary problems that often bring them to treatment. And I'd agree with James, if we had a wider range of much less harmful nicotine products that people could use, we could substantially reduce the morbidity and mortality that people with alcohol and other drug problems suffer as a consequence of their smoking.
I just want to say I totally agree. I think there are some real issues around how we're structured. So I'm from New South Wales, so I can't really talk to the Victorian situation, but it's probably similar. That we have drug and alcohol, and then we have tobacco control, and they're separate. And the idea, the kind of philosophy in New South Wales is that smoking belongs to everybody. So all healthcare providers should be talking about it and managing it, but every healthcare provider goes, well, it's not really it's not really my job. So it's kind of like this orphan. It's the most extraordinary thing. And so we are not funded in drug and alcohol to do smoking, and, which is kind of crazy. But you're right, it is that tricky thing around, my role as a drug and alcohol worker is to support people to make the changes that they want to make in their life, and sometimes those changes can be hard. And I will always say to people, you could give up everything all at once. We could give that a go. I've never had anybody go, yeah, that sounds like a great idea, Hester. And our focus and their focus is on the ones that are causing the most immediate harm. So we won't get into drug law reform, but illicit drugs cause harm because they are illicit, and their focus is on that. And because of our funding, because we're small organisations, we've got small capacity, we're not always allowed to, or we don't have the capacity to continue seeing people to get them to that next step of changing their tobacco, which in my experience is always the last thing to go. And Wayne, you're absolutely right. That's what they die on. And so that's one of the things I would love for you guys to go away from today, is thinking, how can we do this better? How can we support the people that we see who do, not everybody wants to give up, but they might be in the future. But for me, a lot of the people that I see have had repeated goes at trying to give up, and they've failed. And this potentially, for many people, they're a group of people who have failed a lot. Why would you put yourself through that emotional turmoil again of trying to manage this? So really think about, how can we do this differently? How can we support people? And I think also the problem with programs like Quitline, beautiful, good for a certain group who've probably given up. Not quite so good for the Carls that I see, who have much more complex issues going on in their life, that Quitline isn't enough to support them, and perhaps doesn't get what they need, isn't able to give them the kind of the nuanced care they need.
Thanks, Hester. Okay, we have a question over here. Sorry. James has gazumped me because I've not paid enough attention. We'll go here first and then over here to you. Thanks.
G'day, folks. Thanks for your time. I was just curious to hear about how you collect. You spoke about how it's an adult issue. Are there any discrepancies with how we collect data from adults opposed to young people and if that kind of contributes to that view, that it is an adult issue, particularly. Maybe Dr. James.
Thanks for the question. I can't really answer that. I can't go into the details of the methodology with the National Drug Strategy Household Survey, and I'm not a quantitative researcher, but I will tell you what I've been told by quantitative researchers working in public health and elsewhere is that is the gold standard. My understanding is that someone sits with someone while they collect the survey data, different from like a phone survey or something like that. But perhaps someone else can.
You need to be housed.
Right.
So if you're homeless, you're not involved. So there are different.
Yeah, right. Yeah, quite right. Questions? Yeah.
There might be somebody else who has a reflection on that too as we go. There might be somebody with the expertise on the survey methodology and so on that we might come back to. But James, did you have something to say?
Oh, we're just going to go here, then here, then right.
Oh, okay, thank you. So thanks for your patience over there. Michael.
Hi, Michael White, South Australian Network of Drug and Alcohol Services. I want to go back to the youth issue. My concern is that what we see is a lot of young people at the minute stopped and searched by police or engaged with by police on the basis that they may be carrying illicit drugs. With the criminalisation of vaping that we're seeing at the minute, and particularly the moral panic about young people, what we're starting to see is police stopping young people who are vaping. And the young people don't get charged with vaping. Vaping has nothing to do with it. The charge is refusing a legal direction of a police officer or threat to harm because they swear at the police officer, and that's a technical assault. And I think we really need to address this issue because that's where you lose out on the human rights and the ethics of all of this. And adult vaping, I think, is a solvable problem. What's not solvable is the criminalisation of children in this space.
Does anyone want to comment on that, James?
Yeah, I can usefully reflect on that. I think you're absolutely right. And, we saw this when the vaping regulations started to be tightened. There was a teenager in New South Wales who was arrested and, pretty violent altercation with a cop because he had a vape on him. It's hard to imagine the last time you saw this with a teenager who was smoking, being harassed by police, which is really weird. But I think it speaks to the dangers of a prohibition model, of the criminalisation kind of approach, because we see this consistently with the war on drugs. The war on drugs, of course, is the war on drug users, but even more specific than that, it's particular kinds of drug users. It's ones who are out in public, exposed, who are usually from more vulnerable populations that are always inevitably subject to, stop and search, and that, police have a lot of discretion in how they exercise their powers, but, they tend to pick on the same kinds of people. And I think the approach we have with vaping, just makes that disproportionate impact on those vulnerable groups more significant.
Yeah, thanks, James. Mary, I can see you nodding furiously, and I wonder if you wanted to just chip in there.
I do, but this is really speculative. So some of my professional life involves speculation, I'm afraid. But yeah, I guess I just wanted to add that I suspect that part of what is going on here is to do with devaluing the rights of some groups in relation, relatively to other groups, and that devaluation is, it starts to seem acceptable because those groups are stigmatised. Yeah, that's what you say.
Yeah, no, absolutely. All right, we'll come here, and then we've got another question over there.
Thank you. It strikes me how so often we talk about what seems to be a new issue, but at the heart of it and some of the background concepts are the same and how sometimes things never change. So I've sort of got two questions about that concept, how history tends to repeat itself in many different ways. One is, are there any similar historical public policy challenges which indicate how this may play out to some extent? And the second one is totally unrelated to that, but about history always repeating itself, and that was about, James, you mentioned how we seem to be seeing a peak in youth use of vaping in young people, and I'm interested in how historically we often see sort of new and emerging drug trends or trends in how a drug is used, which can be very time limited and literally trends, like trendy, and then will dissipate. So I'm interested a bit more about what we're seeing there. So same concept about history repeating, but two very different ones, two different questions about that.
I might just speak to the second part of your question, then I'll pass the mic on. I think it's been really interesting to look at what's worked in reducing illicit drug use and related harms amongst teens. If you compare, illicit drug use versus licit drug use amongst teens, we've got rates of drinking and risky drinking falling dramatically. If you look over the past 20 years, rates of smoking have fallen through the floor in the recent decade very much. I think vapes have been a central part of that. But in both instances, those policy wins, public health wins, have occurred in a context of adult legalisation. So we haven't banned alcohol. You can walk into any adult can walk into a bottle shop around the corner. You can buy alcohol in whatever strength and whatever flavour you want, even if those flavours, in bright packaging, all the stuff that's levelled at, the vapes are marketed towards teens. You can buy a tropical flavoured beer with cartoon characters on it, and nobody's kicking up a stink about that. And I think, but if you look at, say, cannabis use, for example, that has been increasing amongst teens. So, it mystifies me why we are we're using a prohibition model to reduce illicit drug use when these other models are actually much more effective.
I wonder, Wayne, were you going to chip in there?
Just to the first part about history, I mean, one of my retirement projects has been looking at the origins of cannabis prohibition in the USA in 1937, and there are lots of striking parallels. It's often misrepresented as an act that was directed at Mexicans. In fact, it wasn't. It was largely driven by a panic about adolescent marijuana use in New Orleans. And it was seen as a precautionary form of prohibition to prevent youth uptake. And in a sense it did, because there wasn't a lot of uptake in the 30s, and then there was World War II, and it really wasn't until the 50s and 60s that we started to see that sort of uptake. But what tends to happen, I think, with prohibitory policies, and we've seen it with the e-cigarette policy, is evidence of failure is taken as a need for trying harder. Increase the penalties, more enforcement, and we're hearing that at the moment with the e-cigarette bans, that as though the police haven't got enough to do, that they should be out there busting people for using vapes or selling them. I think it's a sad reflection that we tend not to learn from those sort of experiences.
David, I wonder if I can just quickly bring you in, because that question from the audience asked us about other areas as well of public policy that we might reflect on, or from which there might be lessons. And you mentioned the COVID inquiry recently that you feel has resonance here. Are there other areas within your expertise or from your perspective that you think are useful for us to reflect on?
Look, it's a very good question. I think that the public policy is often it's a case of where power gets exercised to define some things as bad and other things as being acceptable because of the way power is exercised from diverse interest groups rather than what the evidence is. So I think if you looked at the evidence at the moment, you're probably wanting to focus on alcohol and tobacco, and you wouldn't be looking so much at vapes. And yet all of the attention is in the wrong way. I think that's the point that Wayne and James have been making. The history of public policy is not a really proud one. I mean, often it is driven by a moral imperative, and usually it's around workers, a sense that if workers are given access to something, they will become less productive. The other arguments, the public health arguments, are just spurious. So I think what all this research is pointing to is a deeper question: is why has this happened? Because when you look at the evidence, it doesn't really make sense. The prohibition is an extreme policy position. And that's where I think, what Wayne's talked about his research on marijuana in 1937. There'll be lots of cases you can pick up and you'll find parallels. What I haven't come across at the moment is a bit of research that answers exactly that question. What happened in Australia to make this such a top of list public health concern right now. I don't think you're going to find it in the evidence, the public health evidence. It's going to be more around the power that other actors have been able to bring to bear to make that the outcome. I hope that sort of answers your question. Yeah.
I'll just speculate and answer your query, David. I mean, I think a lot of it's been driven by the fact that vaping took off in private schools and private school headmasters and well-connected middle-class parents who have access to politicians and the media. And a lot of it's been driven by that. And you've seen some pretty extreme responses in terms of locking toilets in private schools so people can't go and vape, putting in detectors to detect vaping, expelling students from schools, which of course they can do in private schools, but it's hard to do in public schools. So I think a lot of it's been driven by that, and as James has said, the extent to which vaping declines in that sort of population, you might expect to see a lot less pressure put on politicians because it'll be seen as a problem solved.
That's extremely interesting. All right, I've got my eye on time, and I know you've been waiting really patiently, so we'll come here for what I think might need to be our last question or comment. Thanks.
This is more like a comment than a question. I'm Renee from Odyssey, and I'm a youth worker and working with young kids in a school setting. And so vaping is quite a big issue around young people. I noticed that the case that you put up, Carl started smoking, using tobacco at age 12. At about age 12 is what we see young people vaping. Curiosity is the biggest factor around that, whether it's tobacco, vaping, or any other new trend. What I think that we're missing here is not in this whole process is marketing, because the vaping marketing has pretty much come out of the song sheet, the hymn book of the tobacco industry, where back in the 60s there would be doctors advertising that cigarettes was good for weight loss and for women and so on and so forth. So if you look at the marketing stuff, it is very similar throughout history around the tobacco, and I think they've just taken that and fed it through in regard to the vaping. I would like to hear some comments and thoughts around thinking it through that perspective.
On that?
Yeah, I agree with you that a lot of the marketing on social media for vapes is very reminiscent of the way in which tobacco cigarettes were promoted. I think it's a mistake to assume that a lot of this promotion is tobacco industry funded. It's private companies. I mean, the tobacco industry is private. It's quite supportive of bans on e-cigarettes. You look at Japan, which is where there's a government monopoly. The Japan Tobacco Company is a monopoly. What has the tobacco industry done there? Banned vapes and allowed the sale of these heat-not-burn products because they're the ones that were produced and marketed by the tobacco industry. And I think the industry sees these products, which a lot of which are coming out of China, as sort of low-cost entries to a market which is competing with them, and it's taking away their business. And that's been the case in the US as well. But I agree that the way in which these products have been marketed is very reminiscent of the way in which cigarettes were marketed in the 50s, 60s and so on.
All right. On that note, I think we might draw to a close because I know everybody will be eager for lunch. So please join me again in thanking James, Wayne, David, Mary and Hester